When the dental pulp is inflamed, it can be a real challenge to manage. The good news is tonight we'll be getting some expert help so that an inflamed pulp doesn't have to be quite so stressful for us or our patients. Welcome back to Gentle Endodontics TV. I'm Peter Norton, and this evening we'll be learning from 6 specialist endodontists. We won't have time to chat about every aspect of dental pulpitis. Instead, we'll be focusing this event on the 2 trending topics of the hot pulp and later on vital pulp therapy. For the first segment of this event, I'm joined by Dr. Paul Nakad, Adjunct Associate Professor Mehdi Rahimi, Adjunct Professor Chankrit Sathorn, and Dr. Mark Johnston. Gentlemen, thanks for putting this event on and allowing us to pick your brains on inflamed teeth.
Thanks for having us.
We'll be hearing from 2 additional expert endodontists later this evening. This event is being filmed on traditional Camaragal land in northern Sydney. We pay our respects to elders past and present. And we want to hear from you throughout the discussion, so please send us your comments and questions and we'll get to as many as we can. If you're watching us on Facebook Live, please switch over to the gentleendodontics.tv website and you can submit your questions there. This session entitles you to claim CPD credit. If you're watching us prior to the 31st of January 2026, you can request a CPD certificate from Gentle Endodontics, and we'll talk later about how to go about that. Our first topic for this evening is the hot pulp. Now, Mark, I think all dental practitioners probably feel a spike in blood pressure when they hear those words. When a patient turns up with a hot pulp, what's actually happening with their tooth?
Yeah, I'd say it's probably one of the hardest things that we have to do as an endodontist. We have a patient that's booked in lower 6, lower 7. Patient's been in excruciating pain for sometimes multiple days. Very, very challenging case. And what's actually happening is it's inflammation of the pulp, and it's a severe inflammation. There's an upregulation in inflammatory mediators, inflammatory cytokines, and there's an increase in hemodynamic pressure on the inside of the pulp itself. And the analogy that I try to explain to patients is that you've got this tiny little soft pulp on the inside of your very hard tooth that only communicates with your body at a very small pinpoint at the end of the apices of your roots. And that pressure has to go somewhere. It's being localized at the tips of the roots right there. Unlike in your skin where something gets inflamed, it can expand. Your tooth's a solid object. It's got nowhere to go. And that's why some patients will even say that it feels like their tooth is looser. It feels like their tooth wants to come out because they can actually feel that pressure that's on the inside there. And the challenging part is to alleviate that pressure, we've got to get into the pulp somehow. And getting that tooth numb enough to do that is an incredible challenge.
So when it comes to numbing up a tooth like this, why can they be so resistant to local anaesthetics?
So there are a lot of theories as to why this happens, and no theory really explains everything. There's the theory that it could be due to the fact that inflammation creates a more acidic environment. A more acidic environment will mean that a local anaesthetic is not going to work as readily, and therefore that's why these teeth don't go numb. But that doesn't really explain why regional blocks aren't going to work. So, infiltration makes sense. Block doesn't quite explain the whole story. There's a bunch of other theories as well. We've got the upregulation of TTX channels. So these are, it's the tetrodotoxin, if I recall correctly, guys. Am I right about that? So these are the same receptors that are affected by the pufferfish toxin. And these receptors are upregulated in patients with a pulpitis. Those receptors are resistant to local anesthetic, and there's a theory that maybe that's the reason why. And there are a number of other theories as well, such as maybe you're getting the block wrong, you're in the wrong spot. There is some evidence to suggest a patient in extreme pain, you're more likely to miss a block, and that can be for a number of factors. You're stressed, they're stressed, they don't want to open up their mouth as wide, they're in pain already, they're stressed about more pain. But even when you have guided anesthesia using an ultrasound, they still don't go numb. And you've got some patients with some anatomical factors. You can have a bifid inferior alveolar nerve, you can have the nerve to mylohyoid. But even when you take into account anesthetizing these accessory nerves and accessory innervation, they still don't go numb. So there's other factors happening as well. And the other part we got to remember is there's also central sensitization that occurs with these patients. So oftentimes this patient will come in, they've been in pain for a while, because there's often a delay before they have to see us as a specialist. And they say the pain started off in the lower jaw, and then now it feels like the entire side of my head is in pain. I don't know where it's coming from. And that also creates an extra challenge for trying to get the tooth numb. So there's a whole lot of possibilities as to why, and none of it really explains the whole picture, because when you address all of those, teeth still don't go numb sometimes.
All right, so we might have to sort of wait for more research and evidence to come to light. Chankrit, how can we go about managing these sorts of teeth?
Usually with the management of hot pulp, I think there are three aspects involved. We start with psychological aspect, and then pharmacological aspect, and then dental management. I put the psychological first because usually we don't get taught much in the dental school about how do we manage a patient from the psychological point of view. We can move on to the next slide. You know, when I was young, I was thinking of reasoning and logic were everything in our life, and I usually brush off everything that it doesn't make sense. But you know, when you get older, you started to question it. And this book, I read it and I had sort of a light bulb moment. This book is about negotiation, about psychology, about human behavior, and in the passage is fears, even if ill-founded, are real fears and must be dealt with. Facts, even if established, may do nothing to solve the problems. It gave me thought, basically, because when the patient come to us, have a fear of dentistry or anxious about treatment, even though in our mind it doesn't make sense because we can't get them numb, but for them, it's real fear. So you think about it, even if it doesn't make sense to us, it's still real for them, and we have to deal with it. You know, sometimes I imagine I look at this slide and think about it. If my young self looking at this slide, I would probably say, hokum, bullshitting, that sort of thing. But if you're looking at the definition of pain, now this is a pure scientific definition. The pain is defined as unpleasant sensory emotional experience, stress on experience associated with actual or potential tissue damage or described in terms of such damage. If you look at this definition, you can see that you don't need a real damage to be fit within the description of pain. You don't need that at all. So as long as the patient feel it as pain, describe it as pain, we as a clinician need to deal with it as patient is in pain.
Now, thank you for your questions. We will get to as many questions as we can. Remember, if you're watching us on Facebook Live and you want to submit a question, please don't send it via Facebook. Instead, head over to gentleendodontics.tv and submit your questions there. Mehdi, how can we maybe set the scene for improving patient comfort?
So, some of what I'm about to say are just experience. So, I suppose there's variable levels of evidence. However, I've been doing this for a long time, and it's very hard to call yourself gentle endodontics because you have to live up to the name. So from the phone call the patient makes to the medical questionnaire that we have, we triage patients. So essentially, we know if they're extremely anxious. We know if they've had general anesthesia, IV sedation for various procedures, perhaps dental. So we can sort of gauge that sense first. So we know they come in anxious, and as Professor Saturn said, anxiety amplifies the perception of what they're going to perceive as pain. And so we essentially, from the waiting room, have a mention of it. So if you've got dental anxiety, we've got a mention of it. If they have needle phobia, we mention dental vibe. We do offer the relaxing herbal tea, even though maybe placebo, maybe low-level evidence. Obviously, I've drank it myself. And by the way, I've got no vested interest in anything I'm talking about tonight, no commercial interest. I'm just talking as what we do. And I'm sure others do it differently, but I think most specialists try their best. I'm sure they've got very good chairside manner, but I don't think we emphasize what's important to the patient. So less than the radiograph that the dentist gets, the patient will go back and say, oh, this was very painful, wasn't painful. So we have ways such as, I'm sure many people will listen to music. If it's the right kind of music, it would reduce the blood pressure and heart rate. There's some evidence about that. Distractions, such as listening to music by headphones or watching something on a TV. Changing the zinc oxide eugenol smell, because some people can associate that to dental surgeries. Aromatherapy, neutralizing at least odors, if not introducing low-level evidence again, lavender, for example, as a smell has proven to reduce anxiety. And then once we're treating that patient, we are using some hypnosis techniques, from breathing, from distractions such as like tapping them as we're giving them an LA, and talking to them really along the way to make sure they're okay. So I think all of those things, creating that environment, the colors of your practice, like making them warm, gentle, giving couches to patients to sit on, making the lights lowered or dimmed. And I know one endodontist in the past used to use even candles in the room with scents, and I think that will help. I think that will really help reduce patient anxiety.
Do you think that the demeanour of the clinician can play a role?
Oh, for sure, definitely. I think being confident, at the same time telling the patient that we can get through this. We know you're in pain, you haven't slept the night before. They come in a very inflamed situation, but they're also very anxious and tired. So we tell them about the fact that we can do this together, and we would basically tell them, I tell them that, look, I'll take you through the procedure, because sometimes it's the word root canal. Almost half the time it's the word root canal, almost like the word extraction. It does give moderate anxiety. The other time is really them not knowing and the procedure being a little bit more involved, a bit more tools involved, the rubber dam, everything. So I just take more time. Some patients take a lot longer. Others don't even want to listen. They go, let's start. So patients are different. So you've got to deal with each one differently.
Well, Chankrit, what kind of things do you tell your patients so as to keep them informed and comfortable?
I think people don't like surprises. So if you can perhaps tell them that this is what we are going to do, how you're going to feel before you actually do it. So that's sort of eliminate the surprises. So you mentally prepare them for what to come. And this is basically the script that I use in my clinical practice, okay? This is something that I tell the patient when I feel that they are very anxious. So I say something like, even the tooth is numb, you still feel a bit of pushing, pulling, vibration, pressure. This is normal. This is to be expected. But sharp shooting pain, this is not normal. If you feel it, put your left hand up, I'll give you more anesthetic, okay? It's like you're giving an out to them. And also, people like to be in control. Losing that raises anxiety, definitely. So this is what I tell them as well. I want you to feel that you are in control here. If you want me to stop at any time for any reason at all, just put your left hand up. I'll stop right away. I won't push at all. You take the lead. If you want me to stop, I stop. This is an out for them. So they feel that they're in control here.
Well, Paul, we've talked a bit about the psychology of this situation. What can you tell us about the pharmacological aspects of hot pulp management?
Yeah, look, I think we've obviously alluded to the fact that pain is multifaceted, and we can use these pharmacological kind of methods to sort of help us achieve that. There's a few out there. I think when you think about some of the theories of why we can't achieve profound anesthesia during symptomatic irreversible pulpitis, one of it is prostaglandin-induced sensitization of the peripheral nociceptor. And any type of medication that can try and intervene to reduce prostaglandins overall can help. So there's a lot of studies looking at NSAIDs, specifically ibuprofen, preoperatively to try and reduce pain, but also try and increase the success rate of our anesthetic techniques. And there is some good evidence with that. So I don't mind actually, asking the patient to take some ibuprofen if that is medically indicated for them, obviously. If you look at the anxiety side of patients, like we've just discussed, these patients come in and they're quite nervous, obviously. So you've got a few methods that we can use. One that's been used quite often, benzodiazepams. Now, I think predominantly, majority of people look at diazepam, or the brand name being Valium. I much prefer using temazepam. The reason being is it's a shorter half-life. so it should be able to titrate through the body much quicker. The way that these work is that they're going to affect the GABA receptor, and they're going to increase the influx of chloride ions, so preventing the depolarization inside that neuron and allowing some angiolysis. There's not enough strong evidence, though, for it to actually help us achieve profound anesthesia. So I'm not the biggest fan of it. It's also hard to titrate with patients. You give them a tablet an hour before, and you're not sure how they're going to react. I think another method which I really like and we do use quite often in our practice is the use of nitrous oxide. The beauty about nitrous oxide is not only is it an anxiolytic, we also believe it has analgesic effects. So it also affects the GABA receptors, but also inhibits NMDA glutamate receptors. But we believe that there is some effect on opioid release from the neurons, which we think helps with analgesic effects. And there are studies out there to show that there is a higher success rate of an inferior alveolar block with patients taking nitrous oxide. It's very safe. It's very easy to use, quick onset, quick offset. So I think overall, if you have that ability to use it in your practice, I like to lean on it. I know Mehdi does as well. But to preface this, I know there's a lot out there, but if you really want to learn more, I suggest to go out there, do some CPD courses. I know the ADA New South Wales runs a few. So don't just sit here and take what I've spoken for the last few minutes. Definitely go out there and learn more for yourself, learn how to use it and understand the complications as well associated with it.
Well, on that note, Mehdi, and we're not expecting you to provide a comprehensive nitrous oxide course in the next 30 seconds, but are there any key nitrous oxide pitfalls that we should be aware of?
I think the first thing that's good about nitrous is you can titrate it. So unlike oral benzodiazepines, where you just give one dose and it's unpredictable, at least it's a little bit more predictable or cater friendly according to which patient you see. So you can start, and I often start my nitrous oxide titrations at very low levels, and I gauge how the patient is feeling. I'm very careful in the low blood pressure patients because nitrous at times as they're lying down can bring their pressures lower because the pulse and pressure can come down, and because they're relaxed, that's what happens when you're very relaxed, and they can feel faint. They can even feel nausea. So I always warn patients as they're breathing it, if they feel lightheaded or they feel faint or they feel nauseous, they point to the nose and they point down, and I quickly bring it down. I often tell them, don't be shy, because sometimes they're shy, they just don't tell you. Don't be shy, tell me straight away because I can reverse the effect very quickly. And of course, the therapeutic dose, a lot of people say it's 35%, maybe up to 45%. But I found over the years that even 25% or 20% is effective in many patients. And in some patients, of course, the higher doses, even higher than that. The best thing about nitrous is that it does not cross the blood-brain barrier. So therefore, within 15, 20 minutes, 98% of the nitrous is off out of the body. So what I tell patients, and I do this all the time, I actually give them a time. When they get out of the chair, half an hour. This is the time you're allowed to drive. So that's the best thing about nitrous is they can drive, and it's very safe. And as long as, what I tell them is maybe grab something sweet to drink or eat to get some energy back because they're feeling a little bit woozy at times. And the other very important thing is I found over the years, at the minimum, you got to put the patient on 5% pure oxygen. So at times, due to not timing it well, patient got up too early and they didn't feel well. They felt, faint. They felt a little sick. And that lingered on for a bit longer. So giving them pure oxygen for the minimum period of 5 to 10 minutes is essential to make them feel just as good as before they came in. So it's a really good, predictable drug. And there's obviously an art to giving it. That's why courses, as Paul mentioned, are important.
So 5 minutes of 100% oxygen.
Correct, at the very minimum. If you got more time, go to the 10-minute mark. It doesn't hurt.
All right. Well, Mehdi, what's your approach to local anaesthetic for a suspected hot pulp case?
Yeah, so I love this topic. And so even though what we're talking about tonight may not be as evidence-based or weaker evidence, I still think it makes sense to me anyway. So I'll try to explain. So one of the secrets to making sure patients are not feeling the needle, okay, from the insertion point, is not only inserting a needle only a few millimeters in and injecting anesthetic slowly. And we talk about, wand and other devices. There's one woodpecker device that I think Shankar will mention, which we're trialing right now, which is a really good device as well. But it's more to do with the vehicle of your anesthetic cream. So the compound pharmacy for those needle phobes prescribes per patient, because you've got to measure toxicity and you've got to make sure it's right. The cream for me. More important than the ingredient is the vehicle. And the vehicle being a poloxamer base is gritty or sticky. So it hangs around in the area, because most people, when they use that cream, it just washes off with saliva. It doesn't even work. It doesn't even go to where you place it. So I like it to be sticky, right? Provided you wipe it off, you get rid of it, and you don't put a lot of it, because if they swallow it and it sticks to the throat, it can go really deep and can make them feel choky, suffocating, or uncomfortable. The other part of the ingredient is to mix the ingredients. The reason why we recommend tetracaine is because it goes deeper. It goes into below the submucosa to the muscle layer. And for fillers, they use tetracaine. So these are all very safe because they've been used for years. The right compound pharmacy needs to make it. So people that make anesthetic cream, probably those pharmacies. There's a few around Sydney. The reason why mix the drugs, we can talk about later, but it's to do with the partition coefficient and the pKa. It's a bit complicated, but it's basic biochemistry. And essentially, the cream is number one, followed by the next slide, which is the dental vibe. So more important, in my opinion, and Shankar and I have these arguments all the time, so we agree to disagree, or sometimes. I think everybody can give slow release. They just have to be not in a hurry. In fact, the anesthetic technique I have takes much longer, especially in those anxious patients. It might take half the visit. Getting in and extirpating a hot pulp will be much quicker because it's more predictable when you give it right. So I use the dental vibe because there are studies, again, even though some studies say no significant difference, there are studies that suggest that from needle insertion, them feeling less pain, both in infiltrations and blocks, both in tight tissues such as powder injections, all the way to when you're actually releasing the liquid, patients, because of the gate theory, feel less pain. And we tried it on one dentist I won't name, because the dentist was challenging me. And even the patients attested to it that came to me and went to him, that powder injections are much better than giving them. So it is all about the basics there.
And the dental vibe essentially delivers vibrations to the injection site.
Yeah, and we actually tried it on each other. Like the dentist and I, we had a competition, we gave powders to each other. Yeah.
Great, that would have been a fun team meeting. Well, Shankar, what are your thoughts on computer-controlled local anaesthetic delivery systems?
The picture that you see here, there's three devices. Okay, the left is the wand, the middle is DentaPen, and the right is SuperPen from Woodpecker. All of these devices, they share the same principle. The theory is this: say that our muscle in our hand cannot make a fine movement enough to put the plunger at the slow rate and at the steady sort of rate. So all these things, basically, instead of you using your hand to push the plunger, they use the electric motor to drive the plunger. So the wand, it's a bit bulky, and there's an ongoing cost because you need to buy that needle and the cable and everything. The DentaPen and SuperPen basically pretty similar, so you don't need a special instrument. There's no ongoing cost. You just use normal anesthetic and needle. But the benefits is that when you press the button, you don't need to keep pushing the plunger. So not only it help with reducing discomfort with when you're giving anesthetic, it help with the ergonomics as well, because you can see things clearly and you don't have to move it yourself. You let the motor do the work.
Well, Mark, can you maybe describe your nuts and bolts approach to numbing up a tooth that you think might have a hot pulp? Let's say, for example, a mandibular molar.
Okay, so there's a whole bunch of research that's been done in trying to get patients numb, giving a block, giving something supplemental, using this anesthetic, using that anesthetic, and you'll find that some studies will find one thing, others will find another, and overall they all agree that nothing is a cure-all for everything. But what I do in particular, and I sort of disagree with the slide a little bit here, but that's fine, we all have our own way of doing it. I give 2 inferior alveolar nerve blocks as a standard for every single patient with irreversible pulpitis. And then I'll give half a carpule as a long buckle. I leave the patient alone. I leave them alone for about 5 to 10 minutes. I go and catch up on my notes, catch up on my reports. I let the patient sit up and use their phone. And even if the block isn't successful, typically their pain levels are shaved down one way or another. So they might not be numb enough for me to do something, but they tend to feel a little better. When I come back after that 5 to 10 minutes, I'll then give an intraligamental. I don't do it immediately because out of all of those supplemental anesthetics you can give, that's going to hurt quite a bit in a patient that already has pain. But the long buckle plus whatever of the inferior alveolar nerve block that should have worked has done its job to, take away some of the sensation from the tissues around the tooth. Then I'll give my intraligamental. I'll give them another 5 minutes. And then I'll test out the tooth before I go ahead and do my thing. And typically, sometimes I'll test it out just by probing into the gums, percussion testing, asking the patient how they're feeling as well. Sometimes I'll say I still feel it or I don't. You can ask the patient if they feel numb with the lip and check their lip sign. However, it's not a predictable way of determining if they're numb or not. It's more predictable to actually do a pulp test to figure out if they're still feeling sensation. And then if they're feeling nothing from all of that, I'm happy to go ahead and do my thing. If they're still not numb, I'll give another inferior alveolar nerve block with some more intraligamental, leave them alone for another 5 minutes. Pretty much once I've hit 4 carpules of lignocaine, I stop for the day. I know that the toxicity levels are meant to be, 7 carpules for a 70 kilogram person, but in my mind, if 4 hasn't done it, 5, 6, and 7 are probably not going to do it anyway, and today is not our day to get her done. In that situation, I'll send the patient home. I prescribe them some dexamethasone, 4 milligrams, 1 tablet twice a day. And I ask them to take that and I see them the next day. And typically the dex has done its job to calm things down enough so that I can get them numb the following day. It's not often that the patients are still in extreme pain after they've had the dex for 24 hours.
All right. Paul, do you have a similar approach to LA for these patients?
Yeah, I think I'm pretty similar to how Mark does it. I'll go with the 2 blocks and also with the long buckle. What I do tend to do, and I think the more I look at CBCTs, I tend to see lower molars. Their APCs can sometimes be quite close to the inferior lingual border of the mandible. So sometimes I also give an additional lingual infiltration and just let the patient sit. I think Mark hit the nail on the head there. You just got to give it time. Sometimes we rush into it and the local hasn't even worked yet. So just let the patient sit there for a bit and go from there.
And Mark, when you say you're leaving the patient alone, is your...
my nurse is with them. So
Excellent.
When I say alone, it's more a matter of, I say to the patient now, a watched pot doesn't boil. I'm going to go. I'm not going to be staring at you, waiting for you to go numb. I'm going to go off and I'm doing my thing, but my lovely assistant is going to be here in case there is any drama whatsoever. The patients are kind of happy for me to be gone too, because I'm not their favorite person, obviously. And they just playing on their phone most of the time when I come back, and I don't feel so stressed because now my notes are caught up on, and then we can do our thing. It's why a hot pulp patient at the end of the day is much better than one at the start of the day.
All right. Well, Mehdi, you're going to be leaving us shortly, but could you perhaps maybe summarise your perspective on pain management generally?
I think from the nitrous oxide, I can't stress nitrous oxide enough, to mixing the local anaesthetic drugs. Of course, be aware of toxicity levels of each drug. I did find articaine much better in terms of there's plenty of evidence to suggest articaine is much better at being effective at giving us that anaesthetic that we're aiming for. But I like to mix it due to partition coefficients and PKAs with the Scandinests, with octopressin and the lignocaines. I do, when I can't anesthetize the patient, not only increase volume and mix drugs, but also give it time, as Mark said, so I totally agree with that. But I add the fact that when I pulp test each surface of the tooth, sometimes the palatal surface on the upper six, for example, that's inflamed, or by that matter, the lingual surface, as Paul mentioned, is still not quite, it's still giving a response to the CO2 ice. So according to Al-Sayed and Gabala's paper in 2021, I'm a fan of the gradual pulp test, because since I added that to my already fairly jam-packed, sort of with the local anesthetic cream and the nitrous, I thought I had it, and even increasing nitrous in the painful scenarios where the patient's anxiety is going up to bring their anxiety down. So I sort of adjust nitrous up. I found I didn't have to be honest, give intrapulpals, which are the most painful. So I added supplementals. I added the Gao gates, which I know can be quite challenging, and not everyone in inflamed situations can open wide, or they don't know how to do it right. Even Akinosi with closed mouth, they don't know how to do it right. So literature suggests that we don't have to give them anymore. We just need to make sure we got our block right. It's about the anatomy, and it's okay to give an extra. Most the literature suggesting 3.6 mils at the very minimum for blocks, which is what Mark suggested. So 2 times 1.8, but it's okay as long as you check toxicity to go higher. And I've done 4 or 5, mixed the drugs, and honestly, 99.9% of the time we can deal with them pain-free.
You just got to be careful when you're mixing the drugs. That's the thing. So I don't know about Therapeutic Guidelines version 4, but I know in version 3, because that's the physical clown book that I've got at the clinic, there was one little footnote on one page that said that if you're mixing anesthetics, you got to always go with what the highest toxicity is. So if you're mixing your ligno and your arty, ligno, you got your 7 carpules, articaine, you got your 4 or 3, whatever it happens to be for the patient's weight level. You got to go by, well, that number of carpules overall can't exceed what that most toxic maximum is.
So I totally agree. That's why, at the maximum it's 4 carpules, and one of them is a buccal infiltration, and you don't have to give all of it. So it's like, honestly, 2.5 to 3 cartridges of different drugs. We can get most of them, if not all of them, numb. With some, of course, as Mark mentioned and Paul mentioned, supplementals such as interligamentaries, I find it very useful.
Well, speaking of supplementals, what's your opinion on the role of supplementary anaesthetic techniques like intraosseous anaesthesia for managing these patients? Paul?
I've actually never done an intraosseous because I've never had to. I know there's evidence out there, and theoretically it makes sense. I think there's lots of equipment out there that sort of has that trephining kind of kit with it, and then you inject into it, but I've never had to actually do it. I know some endodontists like to aim for that dental coal and try to aim for that interseptal bone there. Not a true intraosseous, but a similar concept. But yeah, like the boy said, I've never actually needed to use it.
Not only it will give you palpitations, and that's not nice. Even with adrenaline, we didn't really discuss it, but you just got to be careful with some patients that are prone to palpitations, some heart patients, pacemakers and all. So the reality is, I've never done it. I've seen it be done, and I'm like, nah, I'm not doing it. Even if it does give you absolute anesthesia, or there's other ways, there's other less barbaric ways, in my opinion.
The literature seems to suggest the efficiency, because you can get the anesthesia much quicker than whatever we describe, because sometimes it takes us like half an hour to get the patient numb. With the Stabidine and X-tip, I think they can get it in on average 5 minutes, so it saves time. That's a main selling point.
All right. Well, Chang, sticking with you, how do you aspirate when you're using one of the computer-controlled local anaesthetic devices?
It's built into all those devices. So basically, you hit start, okay? So the plunger keeps moving forward. If you hit stop, it will aspirate. Yep. If you want to start again, just hit start again. Yep, that's
all right. And sticking with you, Chandra, since the lowered pH or reduced pH induced by inflammation might be a potential reason that LA is not effective, would buffering the LA just before injection possibly mitigate any interference from the acidic environment?
Yeah, in theory, yes. But again, from practical point of view, it's quite cumbersome to actually do it. But from theory, yes.
And it doesn't work.
Just going to add something.
The studies just doesn't work, unfortunately.
If I add something to that, Stanley Malamed, and a mate of mine, Dr. Andre Tutuvinu, really recommends buffering. So local anesthetics, they have to be with their lower pH form, their acidic form, because that they have to cross the membrane. So it's all about crossing the membrane in the unionized form, then they become ionized. And the body, I know that's one theory, which there's other theories as to why the anesthetic doesn't work. But one theory is it's an acidic environment, so buffering does really is recommended if the anesthetic's not working. And again, that's why I think mixing the drugs can be effective, because of the different partition coefficients of each drug, the PK of each drug being different as well.
Well, Mark, there's a question here that's asking about the new version of the therapeutic guidelines. Now, I've not read that, so I need to be very clear here. But the suggestion here is that the new version may not state that articaine should be avoided for blocks. Again, I don't know that. This is from the question. What are your thoughts on using articaine for blocks?
Okay, so I haven't read TGA 4 either. Like I said, I don't have the clown book for version 4. I'm hoping that it gets published, because I think it's great to have a hard copy. That's my plug to anyone out there. We should get a hard copy. But anyway, so the whole controversy with a block with articaine is meant to be the suspicion that it results in greater complications, right? If the patient has an injury to the inferior alveolar nerve, which, as we know, can happen with a block, regardless of what we're using, that the patient is going to be more likely to suffer long-term or permanent paresthesia, neuropathic pain, something else like that, because of the increased concentration of the articaine. So technically it's more toxic than 2% lignocaine, for example. And there's no real actual evidence that that is the case. Now, having said all of that, there's also no real evidence that an articaine block is better than a lignocaine block. So from my own personal experience, I've never given a block with articaine because I've never seen a need to it. I don't use articaine really for much of anything in my practice except for that long buckle, because from an actual evidence point of view, like, this is good evidence, randomized controlled trials, the articaine for a long buckle is pretty much the only way it's better than anything else. And I think not only because it's got better diffusion than the lignocaine, but, and you guys are welcome to disagree with me, when patients come in with that extreme pulpitis pain, they also don't believe you're going to get them numb, because they're coming in not just with the pain, they're coming in with the fear. And root canal treatments are terrible. It's the worst thing you can possibly have, and now I have to have it, and I'm in the worst pain of my life. They're not going to believe they're going to go numb, and I don't find that lignocaine gives you that overwhelming numb sensation with a long buckle, or with even an inferior alveolar nerve block sometimes. But if you give them a long buckle with articaine, they feel number. Like, how many times have you had a patient, you numb them up and they say, I don't think the anesthetics worked, and you'll tap it, you'll pulp test it, you'll poke it, you'll drill it, and they go, and they're not feeling it, but they're still not convinced, even though you know they're numb. That articaine gives them that subjective sensation that, hey, the anesthetic's actually in there and it's working. So from my perspective, articaine for a block, I don't see a need for it personally.
Can I add something to that? When you make a clinical decision, you need to weigh the risk and benefits, and then you use it accordingly. There's a study that showed there's the articaine block, there's no superiority of the outcome, as in the chance of getting a complete numbness. So the benefits is the same whether you use articaine or lignocaine to block, but the risk of articaine block is minimal. But my thinking is that if there's no benefits, why risk it? Even though the risk is negligible.
It's also about 30 cents per carpule cheaper. So if we're cost cutting in this economy,
It's worth bearing in mind. Look, we're going to take a short break now and be back shortly to discuss vital pulp therapy. Mehdi and Chankrit, this is where we say goodbye for now. So again, thanks for being on the panel.
Thank you for having us.
Yep.
Now stay with us, we're back in a moment. It's now time to turn our attention to the second topic for this evening, which is vital pulp therapy. It's a pleasure to welcome to the desk Dr. Farhad Avini and Dr. Muna Al-Ali. Thanks for being here.
Thank you for having us.
Now, Farhad, vital pulp therapy seems to be met with some scepticism by certain members of the profession. Why do you think that is?
I think because there's no clear-cut diagnosis is quite a difficult thing to diagnose and to predict for the future. So if you haven't had that much experience with it, it can be a little bit daunting. It's not like in dental school you have caries and you know the limits of it from a radiograph. You open it up, you've got clear-cut rules that you're taught. With the vital pulp therapy, there's so many different steps that you may need to adjust along the way to get the success that you want. Like on this slide here, like you can see it's a continuum of what the pulp's going through. It can be healthy, it can be slightly inflamed, and when it becomes pulpitic, you have certain types of symptoms, and then you get to irreversible and then necrotic. So it's a big spectrum of different states that the pulp can be in. And so when you're treating the tooth, you have to keep that in mind, because if you assume a lower part of that spectrum, but it's a higher part of that, let's say it's irreversible, and you're assuming it's irreversible, it may, I use those terms, and those terms can be argued in the literature, in modern literature, but the state is important. So you may get negative responses or negative outcomes and then become quite lower in confidence based on what's happened.
Well, Muna, vital pulp therapy does have a place for traumatised teeth. Are we going to be talking about that much tonight?
Actually, we do want to talk about vital pulp therapy for caries or caries-affected teeth. Vital pulp therapy is a stabled, I would say, or very reliable treatment for traumatized teeth. Obviously, because of the potential for infection is quite less if managed properly and timely manner, but for caries-affected teeth is a different story.
Well, speaking of caries-affected teeth then, is there a place in your mind for direct pulp caps for carious teeth?
Honestly, in my mind, I would not do any direct pulp capping for caries-affected teeth. The reason why vital pulp therapy is a bit difficult possibly for our colleagues is that we need to understand that whatever the patient comes in with symptoms doesn't always reflect what's happening inside the pulp, especially with caries. Sometimes, and a lot of times, like in this case up here, you've got a very deep caries, but normal symptoms. This patient did not even have any symptoms at all, with normal pulp responses, no pain or percussion. But as you see on the radiograph, there is a very, very deep caries that is close to the pulp. And there's also a little bit of widening apically. And the patient is somewhere around 12 years old. So once you look at the pulp histologically, you'll see quite a lot of inflammation there. And you don't know if this has crossed the line toward irreversible pulpitis or necrosis even before you open it up, if that makes sense. When you go and remove caries altogether, if you want to do direct pulp capping, you're basically leaving an inflamed pulp underneath your pulp cap, which does actually show higher failures. So I would not recommend that for caries exposed pulps.
So was the treatment here done by the treatment we're seeing here? Who was doing that?
That would be me.
Yes.
So this young lady was referred to me because of a deep caries that was detected, even though she was asymptomatic, just because of her age, for some fear of managing root canal treatments for kids. It was a bit difficult for the dentist, so they referred over to me. As I told you, I did my normal examination. It was normal to cold testing, normal to percussion, so no pain. And you see on the radiograph the bit of widening apically of the periodontal ligament. I decided, okay, let's remove the caries and see what happens. Obviously, there was some exposures there. I decided to do a mini pulpotomy because, as you can see, there's a big pulp chamber, so I can hope for good healing. And I capped it with MTA and followed it up with a permanent filling.
What are your thoughts then on selective caries removal?
This is, you caught me there.
Okay.
So I actually published a paper about this. It's just a narrative review, but I looked at the evidence and I tried to come up more or less of a guideline or a protocol, simply because there was such contrasting guidelines from big bodies of endodontic societies in the world. To be honest, as I said, starting at the beginning, when you do have deep caries, your pulp is already inflamed. No one can tell how far it's going. And a lot of times, if the caries is deep enough, it will create microabscesses if the remaining dentine is very thin and infected, or if the pulp is involved with the caries process as well. So think about it this way. You remove caries selectively, as in you left something behind. What about the pulp? You might have left a microabscess there, or you might have left a severely inflamed pulp there. Unfortunately, the studies that talk about selective caries removal, some of them are actually encouraging to do selective caries removal. But they forget that, as we said, not everything is reflected in symptoms. So yeah, the patient is fine, but it might be brewing pulp necrosis or severe inflammation in the pulp, and then trouble will happen along the way. So my suggestion, as per the American Association of Endodontics, is to actually remove everything. Expose that pulp if you have to. If it's already exposed, just manage it. And pulp therapy has a really good success rate, so I don't think we should be shying away from doing that.
Well, what can you tell us about this case?
It's actually the same young lady. This is a 12-year-old young lady who had a filling done with selective caries removal principle. It's basically the same patient as the slide before. Unfortunately, she presented with pain and cold, pain on biting, and also her pain tended to linger when I tested the pulp. It was not tended to percussion, but she was not comfortable biting on these teeth, the 2-6 and the 3-6. So again, I decided to just remove the fillings. As you can see, once I removed the fillings, on the middle clinical picture in the top side, you can see a small exposure that is not bleeding. It just tells you that there's something going on in that pulp because of the deep caries. On the other side of the cavity, after I removed just the filling, I was not even removing caries, so you can see a little exposure. Now, whether this was me when I was removing the filling or it's there already, who knows? But at the end of the day, that soft caries needed to be removed. And again, as I said, I don't believe in direct pulp capping. Capping an inflamed pulp doesn't make sense to me, so I just removed a bit of it, as in partial pulpotomy, and we did MTA capping afterwards, and then followed it up with a permanent filling. And the bottom right side is the follow-up after I think 3 years or 4 years, and she's doing perfectly fine.
Good news. Well, Fahad, in a perfect world, what are we hoping to see after performing a partial pulpotomy?
Well, I think the main thing is if the patient came in with pain, that the pain's gone away. I think that's the priority. The second thing is that we see healing, whether that means clinical or radiographic findings. Let's start with the radiographic. If you look at this, I think if you see the arrows pointing to that underneath the amalgam and the pulp capping agent, you can see over time, the 6 months and 18 months, there's a full thickness of like a calcific barrier or a tetradentine. Even in the previous slide, you could see there's evidence of maybe not as comprehensive as this barrier, but you could see some radiographic healing underneath the pulp capping agent. So that's radiographic. And then clinically, you want to see absence of swelling, absence of pain on palpation, on the mucosa, absence of pain on pressure, percussion, just generally the patient's symptoms going away. And if they were absent, if there was absence of symptoms initially, that they don't develop, like no sinus tracts present. And then you'd want to follow that up and make sure that doesn't change over time. So make sure the patient's well after the treatment initially, review them in 3 months clinically, radiographically, review them in 6 months clinically, radiographically. And I think if it's going to be a failure based on endodontic reasons, like let's say you misjudged the inflammation of the pulp, you'd see a failure within those first 6 months. If it's going to be something like related to microleakage or any other non-endodontic reasons, it will happen probably after that, which kind of helps you determine when to finalize all your restorations and put more definitive restorations on.
Well, this dentine bridge formation is amazing to see, but if we didn't see that, are we worried then that the treatment has necessarily been a failure?
Not necessarily. I think it's good to see that as almost a bonus, radiographic bonus as a clinician. But if you've got signs of healing in other ways, then that's also a good thing. Usually you want at least 2 signs of inflammation to go, okay, yeah, this is failing, or this is not going well. You wouldn't base it on just one thing, like the absence of a calcific bridge and a radiograph. Yeah.
Well, Paul, we've talked a bit about partial pulpotomies. What constitutes then a full pulpotomy?
I think it's purely dependent on the degree of inflammation, really. I think in these situations, it's quite difficult to gauge inflammation. It's a histological kind of point here, and we're trying to gauge it clinically. So in these situations, like Mona said, I will remove all caries, and if that exposes the pulp, I'm going to remove that superficial pulp to a point where I can achieve hemostasis. And if that means going to that pulpal floor and doing a full pulpotomy, then by all means, that's where I will go. So I'll be guided by where I believe clinically that inflammation has progressed to and for what I can actually remove.
And Mona, I think all of these cases are yours, but what can you tell us about the images in front of us?
From memory, this is a 40-something-year-old lady who came in with sensitivity to cold and sweats. So she didn't have any lingering pain. She didn't have any trouble in terms of, signs of irreversible pulpitis, but she's just pretty upset, and she does want to use the left-hand side of her mouth. So basically, when I did my examination, as you can see, the 2.5 and the 2.6 showing a bit of a deep caries, I would say. The 2.5 is a little bit deeper than the 2.6. So in the caries terminology, they would call it extremely deep. So they are expecting a bigger pulpal exposure in that area. So I decided to, based on my pulp test, which resulted in normal responses, maybe it's slightly intense response. So I decided to do a full pulpotomy for the 2.5 and a partial pulpotomy for the 2.6, simply because the exposure size that happened in the 2.6 was quite small, and I just didn't see a reason to just, do a full pulpotomy there. There's another reason, is that once I opened up the 2.5, there's a bit more bleeding from the 2.6. And then I decided, that's not going to work out with a partial pulpotomy. And you've got to take into consideration that it's a smaller tooth. So as soon as you remove everything, you're already in the pulp chamber. So it's a full pulpotomy for that one. Yeah.
All right. Well, Mark, we've talked about partial pulpotomies and full pulpotomies, but do some full pulpotomies have to be deeper than others, depending on what we see?
Bit of a hard question, because you really just got to go where the inflammation is taking you, and you can reach a point where you're into the radicular pulp itself in the canal, and at that point it's like, well, what are we doing here? If it's a mature tooth, you're pretty much doing a root canal treatment at that point in time. If the pulp is still continuing to be inflamed deep and deep into the actual radicular pulp tissue, if it's a immature tooth, because of the fact we know all the complications that can happen with an immature molar in a kid, you might push the limits a little bit harder, and it might just be a partial MTA root filling over the top of whatever pulp stump that you can get that isn't going to bleed too much. But pretty much as what Paul said, you're guided by the inflammation, and that's a real tricky one to gauge, because we're sort of trying to get the pulp to stop bleeding, in essence, and these pulps are inflamed. They can bleed quite a bit, and you got to remove a bit more till you get down to healthy pulp tissue, and that takes time as well. It's a bit of back and forth.
I think it's quite important to discuss these scenarios with the patient and their guardians before, so that just in case, if you think, based on these symptoms, it actually might be further than what I'm anticipating, what are the sequelae? What could happen after this? If we have to do root canal treatment, are you prepared for it? Or if the tooth is immature, what are the options? The tooth's not going to continue developing. So I think these are important things to cover.
Discussing this with the patient, I find as someone that does a lot of communication with patients, to be incredibly difficult, because you're telling a patient that, no, we're not going to be doing a root canal treatment for you. We're going to be doing something a little bit different that you've probably never heard of before, that if it doesn't work, you're going to be getting a full root canal treatment, but we're going to try this first to see if we can keep your pulp vital. And trying to explain that to them, that we're not going to know until we get in there. It's going to be a little bit unpredictable until the procedure's actually done. And you do have to say to some, it's normally parents that you're talking to with a kid, that we may reach a point where this isn't actually possible, and we're left with doing a more conventional endodontic approach. And I've had one patient in the past that when I consulted them, between the time of me consulting them and then coming in for the actual treatment, when I opened up the tooth, the pulp chamber and the canals were empty. It had gone from that spectrum of pulpitis down to necrosis in the time it took between consultation and the treatment appointment about a month later. So we do have to let the patient know, and the parents, as the case may be, that, hey, this is more of a number of directions we can take depending on what we find at each step of the path.
Well, I think it might be worthwhile then sort of just getting, Mooney, your approach to actually doing a pulpotomy. What are your steps? Just so we're all talking about the same things.
I would just, first of all, get my diagnosis right first. It's not always easy to diagnose the pulpal inflammation correctly, but based on patient symptoms, plus what we see on the radiographs, depth of caries, even if the symptoms are saying reversible pulpitis, I'm expecting some irreversible change in some parts of the pulp. So I'll be more erring toward a deeper pulpotomy if I'm thinking more symptoms or deeper caries, for example. But I always leave a little back door, as we like to call it, tell the patient that since it's mostly multi-rooted teeth, I might have one canal showing more severe inflammation than the other, or even necrotic, and that will make me abandon the whole procedure altogether. Just keep that possibility. If it bleeds too much and I can't control the bleed, that also will tell me, look, looks really inflamed, and I usually am not comfortable leaving my patients with that. Very little bleed also makes me worry. So it's somewhere in the middle. If the caries is affecting one pulp horn or so, I tend to do partial pulpotomy. I'll just go with what I see. Basically, the caries exposure at the beginning, and then if I start removing part of the pulp, and then I look at hemostasis, the status of the tissue. It's a bit subjective, to be honest, to look at, but we all here have seen very inflamed pulps and normal pulps. So when we're looking at that pulp and it looks nice and happy, bit of bleed, which is normal, it's vital, and I'm like, yeah, that's fine, I'll stop here. But sometimes it's just, that bleed looks pretty dark, pretty angry, then the tissue looks frail, very inflamed. You kind of want to remove that. Like, it's just subjective again, and that's when you go deeper. I like the way Dr. or Prof. Nezrin Taha thinks about it. If you want to err on removing more in terms of partial to full pulpotomy, which I feel makes it easier for our colleagues to kind of avoid trouble as well. So if you want to err on removing a little bit more, I'm not saying the whole pulp, but instead of partial pulpotomy, we go for full pulpotomy. I tend to do my hemostasis with a little wet cotton pellet with sodium hypochlorite. I don't know about you guys, whatever you prefer. And I don't pressure. I just leave it. And usually I leave it in the pulp chamber with another cotton pellet on top of it. If I want to do my notes, do whatever, I am not in a rush. If you keep disturbing it, it will keep bleeding. So we'll just leave it for a couple of minutes, 3 minutes, 4 minutes. The studies would tell you success rate is unaffected by the bleeding. But there's a clinical consideration here. I can't keep the patient sitting there for an hour, right? I have to stop at some point.
Especially because we're dealing with a kid most of
Exactly.
the time as well. You're fighting a battle. Yeah.
Exactly. But in all honesty, I do this for mature teeth too. You have to consider everything. They're sitting on the chair, they're opening the mouth, keeping their mouth open. There's a bit of a discomfort. They're at the dentist. So you don't want to keep them for long. So I tend to stop at somewhere around 10, which is in line with most studies. 10 minutes, I think, is fair enough. If it doesn't stop, then I might even go deeper from doing partial pulpotomy or just abandon the whole thing if I'm doing a full pulpotomy and it's still not stopping to bleed. My bioceramic pulp cap or the MTA pulp cap, I put it on nice and, gently dapping it in, followed by a little GIC, and then followed by the permanent filling. I don't leave the permanent filling with all due respect for my general dentist. Reason being, coronal seal is very important for our success rate. So I don't know about you guys, but
it's also one less step for the patient to go through.
I've
so
been bitten before, that's why.
We have had a question, would you ever use a haemostatic agent for any of these procedures?
No. Hemostatic agents will create a blood clot. And that blood clot is not in our favor. We want it to be as thin as possible. We want to have as less intervention as possible, less materials as possible. And I want that pulp in contact with my bioceramics. I don't want something in the middle. So that's why I don't use it. And pressure is good enough to stop bleeding. We don't need it.
And I'm also assuming these patients have rubber dam on their tooth?
Oh, definitely.
Okay. Look, at a table of endodontists, I thought it was probably an assumption, but figured I should
So
just...
I'll go back a little bit. If you want to do vital pulp therapy, by all means, it's a simple procedure. Everyone is taught to do access cavities, which is pretty much the pulpotomy procedure. If you want to do a vital pulp therapy, partial pulpotomies, full pulpotomies, dark pulp capping, whatever you want to do, rubber dam is a must. You need to isolate this tooth. Make sure there's no contamination. Make sure the pulp is still happy. You don't want to introduce new infections there. Plus, you need to do your good coronal seal, and it needs to be done in a proper manner as well. Magnification is very important because, as I said, in multi-rooted teeth, you'll see a lot of bleeding coming from multiple canals, for example, but one is necrotic. And if you don't have that magnification, you might not be able to see it. And I've seen this happen so much. Dentists, people would be calling, I did this, but it didn't work. Like, how come it works with you and it doesn't work with me? And then you go back and explain, did you see this? Did you see that? Did you try it? And then you realize, no rubber dam, no magnification, no isolation, no. So
there's also the case selection issue as well. So
True.
I guess, one of the things I'm sure people watching this are going to think to themselves is, all right, so we just talked about the hot pulp beforehand, numbing it up to do endo treatment. Now we're talking about inflamed and irreversibly inflamed pulps and doing a vital pulp therapy. How do we pick one patient over the other to do one or the other?
We had a question pretty much exactly on that. Yes.
Look at that. And maybe now that I already figured that out, someone else can answer it. No. So the whole thing, case selection is a real hard one because the evidence in the literature is really bad for case selection. You're literally just going by your own experience. And the experience that I've got with patients is coronal seal is the number one. When you do look at outcome studies, coronal seal is the big one. If it's not well sealed or if it's difficult to seal, it's not going to work. Deep mesial margins, deep distal margins, a lot of the time you're pushing it uphill already. You're not going to be able to get it properly sealed to maintain it long term. Patients' overall caries rate as well as another one, because it worked now. Is the rest of their caries rate under control so it's not going to become recontaminated through dietary factors? But then you've also the patient selection. This is a big one because you need, again, to explain to this patient that we're going to do a procedure where if it doesn't work, you're going to be doing a root canal treatment. And patients have come to you for a root canal treatment with that expectation, as much as they might hate the idea that they're getting a root canal treatment. So you need to say to them, I'm going to try something, and if it doesn't work, even though success rates are high, if it doesn't work for them, it 100% failed. So how are we going to, is this patient someone who can actually understand the procedure that we're proposing to them? And then what's this patient's pain profile? Part of the reason that I don't do this in patients with a severe irreversible pulpitis is they have come in severe pain. What is the most predictable way to get them out of pain? And that is taking that pulp and getting rid of it. Whereas a patient we can have irreversible pulpitis where the patient had severe pain 2 weeks ago. Now their pain is down at the bottom of that spectrum where the wildfire is gone and now it's sort of just a low simmer. Well, they haven't come in extreme pain. There's a good chance what we do to them is not going to get them into extreme pain. So there's also that subjective, what is this patient feeling and what are the odds that they're going to continue feeling bad afterwards, right? That's a tough one because there's no evidence for it.
It is tough, and I agree with you to some extent, but studies have showed that now they're trying to rename the pulpitis or the terminology. So the more severe the symptoms, as in now starting spontaneous pain, now starting to wake the patient up from sleep, the going toward the more severe symptoms, they showed lower success rate of vital pulp therapy, but they did not show fully not successful vital pulp therapy. But you just, again, as you said, you don't want to keep your patient in pain. You don't want to take the risks. That's fine. For me, as you said, I tend to avoid vital pulp therapy in severe cases, as in severe pulpitis cases, according to the new terminology. But at the same time, Prof. Taha also showed that even with severe pulpitis, full pulpotomy actually works. Even if you have pubical lesions, it does work. Yes, lower success rate, but something...
Case selection, patient expectation.
Again, you need an understanding patient.
Now, again, thank you for your questions. We will get to as many as we can. If you're watching us on Facebook Live, remember, if you want to submit a question, please head over to the website on your screen and you can submit your questions there. Farhad, we talked briefly about sort of restoring these restorations with a long-term restoration. Which materials would you tend to use?
Yeah, good question. I mean, because there's quite a variety of different cases that you can get. Whether it's like a child, 10-year-old with dentive vaginitis that's become infected through that protuberance, more likely you're going to just be doing a occlusal access cavity, just a conventional one. It's not going to be compromised in the proximal sides of the tooth. So you'd be wanting to protect your pulp capping agent. So if that's made of biceramic sealer, which it is, cement, then you want to put something on top that's not going to compromise that seal, and not sometimes you get a bit of blood inside that agent and you don't want to irritate that the blood, so avoid resins. Put something that's going to give you a good seal, like GIC cement. Over the top of that, then you can put something that it's going to have a really good bond with the tooth, so composite resin with dentine bonding, as best as possible that you can. Isolated field, ideally aseptic field, so you wipe your rubber down with hypochlorite, anything like that. But then once you get teeth that you're missing proximal contacts, like there's MO or DO, there's a classical paper called Ria Messer, like they've shown that just a normal access cavity through a tooth reduces the fracture resistance of the tooth by 5%. But anything more than that, like an MO or a DO, it goes significantly more than that. So once you've lost a mesial marginal ridge or a distal marginal ridge, you should be considering putting a definitive core, and then later on, when you've deemed success of your vital pulp therapy, usually it's around 6 months, then you can arrange for like a cusp capping material that will be maybe bonded on.
All right. Well, we're running close to time, so what can you tell us about this case?
Well, this is actually a friend of mine. He is a cardiologist, and he presented with just reversible pulpitis symptoms. And I was like, would you like to try something to avoid a root canal treatment? And he obliged, and he wouldn't mind. So I tried to do vital pulp therapy, and I ended up doing a full pulpotomy based on the caries depth, the bleeding, and the tissue status that I saw. He came back in about maybe 3 months or 4 months telling me that it's still sensitive to cold, but then I realized, he's got some perio around the tooth and some gingival recession happening, and that just affecting the pulp as well. So in our studies where we're looking at vital pulp therapy, whether it works or not, one of the exclusion criteria is no periodontal disease. And unfortunately, in his case, there was some gingival recession there. And if I wanted to go in and extend my pulpotomy a little bit deeper to cover that recession area, possible. But then in an adult patient, you'd be like, is it really worth it? Or should I just go for root canal treatment? If you think about it this way, yep, it can be worth it. We are maintaining a vital pulp in the tooth, immunocompetent tissue, some proprioception as well. Yes, it can be worth it. But at the end of the day, his lifestyle, his commitments, and his work does not allow him to keep going back and forth. So we decided to go for a definitive treatment, and we just go for root canal treatment.
Well, Farhad, why then should we be perhaps placing more faith in vital pulp therapy now, given it's possibly had a slightly checkered past?
It's a good question. I think it's more because of better evidence coming along now more frequently. So you've got the hierarchy of the pyramid of evidence base, and we're getting more higher evidence or higher level evidence. That's the one thing. And then also we're becoming a bit more clear, like Dr. Mona said, with diagnosis. So the ESC and AAE, the American European Society of Endodontics, separately are coming together to redefine our diagnoses terminology. So what we learned in dental school as irreversible, reversible pulpitis, there's a lot of confusion between all the different schools out there. And they are clarifying some of those maybe misunderstandings. So eventually we're going to come to a point where we're going to be better diagnosticians and have better evidence, and we'll be able to applying these things more predictably.
I guess better materials help as well.
Exactly.
Yeah, that's true.
Materials, the new materials. The bioceramics are doing a really wonderful job in their biocompatibility, bioinduction properties as well. In the old days, they used to do vital pulp therapy with some calcium hydroxide powder or previous like mixed toothpaste mix or whatever, and it tended to dissolve, and it tended to create gaps, and it tended to cause more leakage. And whatever dentine, or let's just say calcific barrier that forms, was incomplete, porous, with lots of tunnel defects, in comparison to the calcific barrier that forms with bioceramics, a little bit better quality, thicker, so you get better protection for the pulp. I'm not saying full protection, I'm just saying better protection. So you add on top that we have better gadgets, better instruments, better materials. And now we are understanding that inflammation is not just what we see under histology slides, it's also biomolecular. So these bioceramic materials, they actually induce differentiations of the cells, they induce less inflammation, they induce healing potential in the pulp as well. So our understanding is getting better and better, and that's why things are working.
Well, Mona, how does vital pulp therapy differ from regenerative endodontics?
So vital pulp therapy, by definition, is a therapy that you do to maintain a vital pulp. It has to be vital. Regenerative endodontics is supposed to be procedures that you apply for cases with necrotic pulps, so no pulp to maintain really. But what you're trying to aim is to regenerate, which I don't agree with the term, but to regenerate a tissue that resembles the pulp, to actually get some sensibility or some immunocompetent tissue inside the root. Hopefully in doing that, you're also getting some root development.
That's a big topic on its own.
It is.
Maybe a topic for Gentle Endodontics TV episode 3.
Yes.
So quite a few questions to get through and not much time, so I'm sorry to put you under pressure, but that's how we are. Mona, in an adult, would you also be attempting a partial pulpotomy or straight to full root canal treatment? What age is the cutoff and what level of root development?
Well, according to the evidence, there's no evidence to show that the age affects your outcome. You can do partial pulpotomy or full pulpotomy for an adult patient. It's, again, as Mark said, it's case selection.
Right, Fahad, do pulpotomies have a role for teeth with calcified canals?
It's all to do with the ability of the pulp to carry on after you've done your treatment. So if the pulp is in a state where it's not that vascular, it's fibrous, or there's lots of calcifications, it's less likely to be able to protect itself. And so it obviously depends on the amount, but I think if it's very calcified, I wouldn't attempt it.
All right, you'd go straight to full root canal treatment.
That's correct, yeah.
Okay. Paul, do you believe that stepwise caries removal is risky? This person is aiming to remineralise the dentine, given that's what they were taught at undergraduate level, and they're a bit scared that perhaps the remineralisation won't work. What are your thoughts?
Yeah, I just think it's too unpredictable, to be honest. I think the fact that we're leaving caries behind, we know there's going to be inflammation still in the pulp. So I prefer to sort of have a predictable method towards actually treating these teeth. When you look at some of the histological studies, a lot of them come out from Riccucci's team, where they look at when there is caries left behind, we might still seal the periphery, but there's still those saccharolytic kind of driven bacteria that can survive in those harsh areas. So we know that we're going to have active bacteria that can stimulate inflammation in the pulp. It's why we're sort of moving away from stepwise now. We're moving towards vital pulp therapy now. It's a much more predictable treatment.
Actually, selective caries removal started because they were so scared of exposing pulps because they did not know how to manage them. And at that time, the perceived lower success rate of vital pulp therapy. We don't have that anymore. We don't need to be scared about it. Yeah.
All right, good to know. Now, Paul again. What is the best pulp capping? Well, they've said pulp capping agent for a general dentist to use, MTA or others. What are your thoughts?
I think this goes back to, I know the term's used quite often, but the biocompatibility of a material, but also the sealing capacity of it. Traditionally, we've gone from calcium hydroxide. I think now we've moved towards calcium silicate-based materials. The original MTA is great. Forms of it now that are coming out, like Biodentine, are also just as good. So for me, that's where we're headed. I think if you can get some MTA or some type of calcium silicate material, that's my go-to pulp capping material these days.
And Farhad, you touched on this earlier, but for heavily broken down teeth where an indirect cuspal coverage is required, how soon would you recommend placing an indirect restoration over a tooth that has undergone VPT?
I think you want to be sure that your treatment's been successful, and I think you're more likely to know at the 6-month mark after a radiographic and clinical review, and I think then you can do it, but the patient needs to be aware that it can still fail after that point.
When you mentioned using sodium hypochlorite on a cotton pellet, does rinsing the pulp with saline have any benefits?
Actually, you can, but there is a study, I think it was a group of, it's named Balal, I think in 2022. They showed actually when you use hypochlorite, the response of the pulp to pulpotomy is actually much better, and you get better control of the pain as well. The thing is, when you're removing caries and you get to the what we call hard dentin, you can't guarantee 100% that it's bacteria-free. It is the least infected, I would say. And then you put hypochlorite on top, which can help disinfect it. And then on top of that pulp tissue or pulp stump, let's just say, that you did some pulpotomy, some form of pulpotomy on it, you can actually do what we call, or what I call, a chemical pulpotomy, because it will dissolve a tiny, tiny bit. So it might actually help remove a little bit extra.
I think it's a misunderstanding, like when I was saying with infected and affected dentine that we were taught in university. They have found bacteria in affected dentine and vice versa, so you can't fully rely on that.
Good to know.
If I may just add something, it just popped in my mind when you're talking about restorations. If the tooth is indicated for intraradicular retention, as in you need it post, obviously, vital pulp therapy is out of the door. Like, you can't do it. So that's another thing that we need to think about in vital pulp therapy.
All right. Well, Mark, given the ageing population, is vital pulp therapy just delaying the inevitable of a pulpectomy in future, given no treatment lasts forever?
Well, you can always take that argument, further and further and further. Patients say this all the time. So if my root canal treatment is only going to last 30 years, why should I bother? Why not get it out and get an implant now? Don't those Facebook ads that Meta pay for say they last forever? So at the end of the day, I know me as a patient, I don't want a root canal treatment. I do them every day. I don't want one. So if I'm going to treat people the way I want to treat myself, I'd take a vital pulp therapy that gives me 10 years without a root canal treatment than just sacrificing that and going straight down root canal treatment territory. And just from a pure will bad things happen to this tooth point of view, a tooth that's been fully endo-treated and then likely crowned as a consequence as well, versus a tooth where it's got a vital pulp, still got some proprioception, hasn't been completely cored out. I think it was the Kaplan study in 2002. You're 6 times more likely to have something bad happen to that endo tooth over the lifetime of a patient than to the tooth that hasn't had endo treatment. So whilst we might be delaying the inevitable for an aging population, the success rates of vital pulp therapy, at least in the early, the short years that we have of them with MTA and bioceramics, we're talking 80 to 90%, in some cases even higher than 90% at 2 or 3 years. We don't know what the drop-off is over a 20 to 30 year period of time, but we still do Schweck pulpotomies to anterior teeth when they've been traumatized. We don't go straight to endo for the same reason. So from my perspective, there's absolutely no harm in maintaining the pulp for as long as possible.
Well, when you touched on this earlier, but given that it's difficult to make a histological diagnosis or impossible to make a histological diagnosis in a clinical environment, do you ever have to bring a patient back into a full root canal treatment after? No, this question is, do you ever bring the patient back into a full pulpotomy after doing a partial pulpotomy, or would you go straight to full root canal treatment?
I'll just start. It's not impossible to determine the inflammation chase side. There are some studies that are working on biological markers to tell how far the inflammation is going. It's not yet translated fully to clinical, but I'm hopeful someone will pick it up and pay funding for the research. But for that, yes, I've done it before in some patients, understanding patients, obviously. Yes, I removed a tiny bit of your nerve. Hopefully that will help you stop the pain. If it doesn't, we can always remove more or just go for root canal treatment. And yep, they come back, we do full pulpotomy. Most of the time it actually worked, and I did not have to go back for root canal treatment. I don't recall going back deeper and deeper again for root canal treatment, so yeah.
And Farhad, many may argue that Voltapulp therapy works well on immature teeth in general. Can we, however, routinely recommend VPT for the treatment of irreversible pulpitis in mature permanent teeth, given modern evidence, or is root canal treatment still the gold standard?
I think, yeah, it comes back to the accurate diagnosis of what's happening in that pulp. We don't have the most accurate tool that detects it. There's no 100% in any diagnostic tool. So we use the symptoms, we use the tests that we do in the consultation to determine how inflamed that is. And if it's a very inflamed pulp, like hot pulp that they were discussing before, perhaps it's less likely going to work. But if you're getting early pulpitic signs, then perhaps it's more of a sign that it will work. So I think you have to put all the evidence together to get as a surrogate measure of what's happening inside in terms of inflammation to be able to predict the outcome.
And again, you touched on this earlier, but in performing a partial pulpotomy, would you only remove a certain amount of pulp tissue and then assess for hemostasis and then continue to remove more if needed? Or if hemostasis isn't achieved on your first attempt, would you go straight to full extirpation?
So spec pulpotomy or partial pulpotomy originally was 2 millimeters removal of tissue. The mini pulpotomy, or as I like to call it, is a little bit less because sometimes it's just a small exposure in the pulp and you don't need to go as deep. You need to look at the tissue that is resulting after the pulpotomy. If it is nice and healthy, by all means you can stop. But if it, as I said, looks a little bit iffy or a bit frail, you need to remove more. And as I said, again, if you want to err on removing more, so you can guarantee that you remove most of the inflamed pulp.
But this is why magnification is so important.
Yep.
I think if you're not having, some really good mag on your loops,
Yep.
I think it becomes very challenging to do Vitapulp therapy because you can't visualize the pulp. You just don't know what type of, healthy or inflamed or necrotic pulp that you've got sitting in front of you, unfortunately.
Especially in multi-canal.
Exactly
Yeah.
right.
Yep.
Yeah. Paul, sticking with you, with direct pulp capping, possibly controversial, given what we've talked about, should sodium hypochlorite be directly applied over the exposed pulp before applying your MTA, your biodentine or your Dical?
I wouldn't be sitting there putting your syringe into the pulp. If you're going to go with a direct pulp cap, I've got no issue, flooding that area or allowing the sodium hypochlorite to actually flow over there. There's no issue, just like what Dr. Moona said. There's going to be bacteria there. It's going to help. Just don't put the needle inside the pulp.
I would rinse it though afterwards, just so that it doesn't affect the bonding.
Now, Moona, sticking with you, if we do a full pulpotomy in a molar and then have to go back and do root canal treatment later, how hard will it be to get to the canals if we've used a bioceramic?
Actually, this is one thing that we need to be aware of. So full pulpotomized teeth, what happens is that the pulp usually narrows the canals a little bit. Sometimes when the failure or whatever reason you're going back into the tooth is delayed, that calcification can be extreme, where it's a bit hard to find the canals. From experience, I found that the calcification is just in the coronal third. A lot of times it's exactly like a normal barrier. So a lot of times, as soon as you go a little bit deep into the canals after you remove the MTA, which you can drill out, by the way, ultrasonicate out or drill out, whatever you want. As soon as you go 2 millimeters below the orifices, you drop in a canal. So it's nice and easy. And I've done a few cases. Not mine.
Again, you touched on this earlier, but can vital pulp therapy be done on teeth that have radiographic periapical lesions?
Oh, definitely you can if you have a vital pulp in the tooth. The previous notion where we said to have a periapical lesion, the pulp must be necrotic, is now being very much challenged. And there's a good body of evidence again, I'd like to say by Professor Intaha again. She's also a Melbourne grad, but she's also a Jordanian. So she's done quite a lot of work on this, and she actually showed amazing healing.
All right. So look, I guess with all things, we'll watch the space and gather more evidence over time.
Yeah. I just have to say it's a little bit less success rate than no preapical lesion, exactly like a root canal treatment. That lesion is just signifying or telling you that there's a little bit more inflammation there.
All right. Look, unfortunately, it's time to sign off. So once again, thank you to our panel of endodontic experts, Dr. Farhad Avini, Dr. Paul Nakad, Dr. Muna Al-Ali, Dr. Mark Johnston, Adjunct Associate Professor Mehdi Rahimi, and Adjunct Professor Chankrit Sathorn. Thanks for sharing your insights on how to deal with inflamed pulps.
Thank
Thank
you.
you.
Thanks for having us.
And thank you for watching. If you're watching this event prior to the 31st of January 2026, you can claim your CPD certificate by clicking the feedback link on your screen and completing the feedback form. If you'd like to learn how to avoid how endodontic complications can be avoided, minimised and managed, you'll find episode 1 of Gentle Endodontics TV on the Gentle Endodontics YouTube channel. And finally, if you're needing assistance with a patient you're treating, you'll find the Gentle Endodontics referral form at the bottom of your viewing page, or you can use the electronic referral facility on the Gentle Endodontics website. Alternatively, you can always contact Gentle Endodontics via the contact details that are currently on your screen. Enjoy your evening, and thanks for watching Gentle Endodontics TV.